A very good evening to all of you, and we are glad to start again the PSI online lecture series from PSI Education Committee. And this evening we have Dr. Vinay Chitturi, Associate Professor, AIIMS Rajkot, who has a very profound interest in neurophysiology and electrophysiology. And he is a wonderful speaker. He has already been, we have two of his wonderful lectures in cardiovascular action potentials and ECG. And today he would be covering cardiac conduction system. And welcome, Dr. Vinay. Uh, I think without any further delay, we can just move on to your presentation today.
Thank you so much. Thank you so much. I'll
Yeah,
start with the definition. I hope the slides are visible.
yeah, the slides are visible. I think it should be in a presentation mode, Vinay.
Yeah, it's in.
Yeah, it's fine now.
One second, let me fix this.
Now, yeah, it's not yet in a presentation mode. I think it's better if you share your whole screen.
Got it. Okay, understood the issue. I'll fix it now. Ah,
Yeah,
yeah.
yeah,
Good evening again and welcome back if someone's seen my previous lecture, right? Previous lecture we spoke about cardiac action potentials, about how there are specialized cells which are pacemaker cells like the SA node, which spontaneously produce potentials which propagate to the other parts of the heart. And when electrical excitation reaches those parts of the heart, they fire the respective potential. So here you can see a representation of that. So a sequence of potentials produced along different parts of the heart as conduction is taking place from atria to the ventricles, right? So, brief overview of what are the pacemakers of the heart, then the cardiac conduction system through which the impulse propagates through the heart, and how does it rhythmically excite the heart in a specific sequence, and a little bit about excitation, contraction, coupling, and abnormal rhythms of the heart. So we already saw cardiac action potentials in my lecture, in my previous lecture. So the one on the left, this one's a ventricular myocyte action potential, different phases corresponding to different cardiac currents. Similarly, pacemakers have spontaneously produced pacemaker currents, which give rise to automaticity, which gives rise to the pacemaker potentials, right? So the primary cardiac pacemaker is the SA node, right, located in the posterior wall of right atrium. It has the highest rate of firing, roughly around 70 to 80 per minute. Now, this pacemaker typically drives the entire heart at the same rate as this, assuming normal conduction takes place, right? And if there are any pacemakers below it, they are theoretically capable of producing their own independent rhythm, but normally they are overdriven by the SA node's rhythm. But if there's anything preventing a conduction, these lower pacemakers may escape from the control of the higher pacemaker and fire independently. We would call those escape rhythms. So the AV node has its own spontaneous rate of around 40 to 60 per minute, and the Purkinje fibers, these are the small terminal branches, they can fire at a rate of around 50 to 30 per minute, right? So typically what happens is one primary pacemaker, SA node in this case, SA node produces action potentials automatically in rhythmic pattern at a specific rate. Now this current of these action potentials will propagate cell to cell, depolarize the neighboring cells, and the neighboring cells also produce their corresponding action potentials, and the entire heart or all cardiac muscles connected to the cardiac system, conduction system, would produce pacemakers at a specific would produce action potential at a specific rate, and that would subsequently lead to cardiac contraction. Right. So typically, as a schematic representation of what's happening in cardiac conduction, so pacemaker currents automatically have slow pacemaker currents. So this spontaneously lead to entry of charge, depolarizing the cell. Right. So depolarization spreads to the cell. Then some of this positive current will go through the gap junctions in the interconnected disc to the neighboring cells. Right. So the conduction speed will depend on the number of gap channels and the size of the depolarizing current. So depolarizing current, when it propagates to the gap junction of the neighboring cells, will depolarize the neighboring cell, and this would lead to opening of sodium voltage gated channels, and they would form their own action potential. So this is how current and action potential spread across the heart. So typically you may see a sequence like this. So one cell depolarizes, current flows through, action potential that would lead to action potential production in the neighboring cell, and the action potential spreads along the heart. Right. Now, there are specialized cells in the cardiac muscle, which are called the conductive tissue. So, they do not have many contractile elements of actin, myosin, and myofibrils, but they are specialized for rapid conduction. So, some of these specialized cells include pacemakers, and the interconnecting conductive tissue. So, SA node is a pacemaker, AV node, atrioventricular node is a pacemaker. Now you have this specialized pathways called interatrial pathways, right? Anterior, middle, and posterior interatrial pathways. They're called the atrial internodal pathways. Sorry, and then the bundle of His goes through the fibrous ring between the atria and ventricles, divides into two branches. We call them the left bundle branch and the right bundle branch. And the terminal fibers of the bundle of His are called Purkinje fibers. So this is how the cardiac impulse has a highway to travel along the conduction system. So also cardiac impulse does propagate cell to cell across the atrial muscles and ventricular muscles too, but this is a faster way through which cardiac currents can rapidly travel across the heart. It's like a highway for the heart, right? So typically, how does this sequence happen? So the cardiac action potential is generated from the SA node, the primary pacemaker of the heart. Now, as depolarizing currents spread, they spread in a specific direction away from the SA node. So they will spread across the right atrium. So at around 10 milliseconds, the initial part of the right atrium will be depolarized. Then in the next 10 milliseconds, a more part of the right atrium. Over 30 milliseconds, the right atrium is fully depolarized, left atrium is starting to get depolarized, and you are reaching the AV node. So, so basically, over a period of 90 milliseconds, the entire atria gets depolarized. But keep in mind, at 30 milliseconds, the AV node has started to depolarize, right? So SA nodes and so if you say conduction speeds, nodal tissue have very low conduction speeds, SA node and AV node, whereas atrial pathways have a slightly faster conduction speed. So if you see the timelines of atrial depolarization, if we start at 0 milliseconds in the SA node, we reach the AV node at 30 milliseconds, and we reach the last part of the left atrium at around 90 milliseconds. And because of the anatomy of the SA node, the right atrium would finish depolarizing before the left atrium, right? So now what's happening at the AV node, right? So we already saw how atrial depolation takes place. 30 milliseconds in, we hit the AV node, and a slow conduction across the AV node. So AV node has low number of gap junctions. So this slowing down of conduction, it takes around 90 milliseconds to cross the AV node, right? So if you can see 30 milliseconds internal pathways, AV node is activated. It takes around 90 milliseconds, 90 to 100 milliseconds to cross the AV node. Then the bundle of this penetrates through this fibrous ring between the atria and ventricle, and eventually the first part of the ventricle septum gets depolarized at 0.16, 160 milliseconds. So zero we started from the SA node. Around 160 milliseconds, the ventricle started to depolarize. Now, what is the functional significance of this AV nodal pathway? In a normal heart, this is the only electrical conduction between atria and ventricle. There's a fibrous ring between atria and ventricle all around, and this is the only electrical conduction pathway between atria and ventricle. And this AV nodal delay ensures that atria are activated before the ventricles so that during the cardiac cycle, atria contract before the ventricle contract. This allows for adequate filling of the ventricles and proper pumping action of the entire heart. Right? So if you can see the bundle of his penetrates to the fibrous ring separating the atria and the ventricles. It's the only pathway. So if you'll see, because all the cardiac muscles are interconnected to each other, we consider them to a syncytium. So this is an atrial syncytium, this is a ventricular syncytium, and the bundle of his pathway is the only electrical connection between the two syncytia for electrical continuity. So we already saw atria depolarized, avinodal delay. Now the ventricular septum is the first part to get depolarized. This gets depolarized through the bundle of His and its branches. So if we see the sequence of depolarization, the ventricular septum depolarizes from the left to right. Right, this is because of the nature of the bundle of His. So left to right depolarization. Right. Then after the septum, the first part of the ventricle to depolarize is the ventricular apex, right, through this bundle of his Purkinje fiber system. And if you see the ventricular free wall, the depolarization is going from inwards to outwards, endocardium to epicardium. So this is the consequence of the anatomy of the cardiac conduction system. So ventricular apex and ventricular endocardium is the first part to depolarize, right? Then slowly the depolarization spreads across the thickness of the ventricle, what we call the free wall of the ventricle, and the entire ventricular free wall of the left and right ventricle gets depolarized simultaneously. Somewhere around this time, the atria repolarize, right? So if you see the ventricular sequence, ventricular septum, ventricular apex, ventricular endocardium, ventricular epicardium. Then the last part of the ventricle is towards the outflow tracts, very close, what we call ventricular base. So that's the last part to get depolarized. So if you'll see, ventricular base is the last part to get depolarized. So that's the depolarization sequence of the ventricle. Ventricle septum left to right, ventricular apex and ventricular endocardium at one time, ventricular epicardium of the free wall, and the last part is the ventricular base. Now, if you see the complete sequence, looks something like this, right? So, if you see the conduction speeds, we already saw SA node and AV node have the lowest conduction speed. Internodal pulses are slightly fast. The bundle of his Purkinje fiber system is the fastest conduction speed. It has a conduction speed of roughly around 4 meters per second, the fastest conduction speed. So, that's the reason it's called the ventricular highway. So because the conduction speed is so fast, right? We have a scenario where if you'll see, atria took around 90 milliseconds to depolarize from zero. The first part of the ventricle started depolarizing at 160 milliseconds, accounting for the AV nodal delay. Now, from the first part of the ventricle to the last part of the ventricle, ventricular base, it is 220 milliseconds. So just a period of roughly around 70 to 80 milliseconds is enough to depolarize the entire length of the ventricle. Right? So this is because the ventricular conduction system, Badrafis and its branches and Purkinje fibers have rapid conduction. So even though ventricles have large mass of tissue, they depolarize rapidly, and both left and right ventricle depolarize simultaneously. So they can pump in synchrony. Right? Now, repolarization of the ventricles. So as a concept, we can remember that the first part of the ventricle to depolarize would also be the last part to repolarize, or last part of the ventricle to repolarize is the first part of the ventricle to, sorry, last part of the ventricle to depolarize is the first part to repolarize. So the repolarization sequence in many ways is reverse to the depolarization sequence, right? So the base will be the first to repolarize. Then the epicardial ventricle muscle repolarizes first. Then finally, the endocardial ventricular muscle repolarizes first. So by how can this be explained? So this can be explained by the different ion channels present in these two different subtypes of muscle and the duration of cardiac action potential. So if you see endocardial action potential is longer compared to epicardial action potential. So if I superpose them, endocardial action potential, epicardial action potential. So endocardium depolarizes first, also repolarizes later. Epicardial muscle depolarizes later, but also repolarizes first. So if you see the sequence, it always looks like the endocardium is more depolarized compared to epicardium, both during depolarization and repolarization. Right now, how can we study this, and what are the functional importances of studying the cardiac conduction system? So we can pick up rhythm abnormalities by recording the waveforms associated with this spread of current across the heart. So if you'll see, spread of current across the atria gives us the P wave, atrial depolarization. Right? Then the depolarization sequence gives us the QRS complex. The repolarization sequence gives us the T wave. So if I play the animation, you see P wave, QRS complex during depolarization, and during depolarization we get the T wave. So P wave corresponds to atrial depolarization, QRS complex corresponds to ventricular depolarization, and the T wave corresponds to ventricular repolarization. Right now, how is this affected by the autonomic innervation of the heart? So we already saw autonomic innervation has an effect on the pacemakers. Right, it affects the heart rate. Right. Parasympathetic stimulation to the vagal nodes would decrease heart rate. Sympathetic stimulation of the SA node would increase the heart rate. Right? It also affects the muscle by increasing the strength. Then it also affects cardiac conduction speed. So it's a property called dromotropy. Right? So sympathetic system increases conduction speed, parasympathetic system decreases conduction speed. So if you see, parasympathetic system through its action on the acetylcholine muscarinic receptor subtype 2 has a negative effect on multiple cardiac properties like chronotropy, bathmotropy, which is excitability of the cardiac pacemakers, and conduction speed of the cardiac conduction system. Now, it also has an indirect effect through its effect of heart rate on inotropy. Sympathetic system through norepinephrine beta 1 receptors has a positive effect on all cardiac properties: increased heart rate, increased excitability, increased conduction, increased contraction strength. So typically, if you see, the spread of impulse across the heart would lead to production of action potentials at different parts of the heart. Now, typically, calcium enters through the depolarization phase or the plateau phase of the cardiac action potential. Calcium entry would activate the excitation contraction coupling system and lead to cardiac contraction. So the specific sequence of electrical excitation is followed, as studied in the ECG, is followed by the sequence of cardiac contraction. So when atria depolarize, atria contract; when ventricle depolarize, ventricle contract. And the AV nodal delay always ensures that there is a gap between atria and ventricles to ensure that linear pumping takes place to the atria, to the ventricles, to the outflow tracts. Right? So, what are the things that can go wrong with the cardiac conduction system and cardiac pacemaker systems? Right? So there could be issues with the pacemaker. So there could be abnormal rate. So the normal SA node could be firing at a high rate, could also fire at a low rate. We call this sinus tachycardia at high rates or sinus bradycardia at low rates. Right? Now sometimes the pacemaker location may get damaged because of abnormal conduction from the higher pacemaker. So in that case, lower pacemakers can escape the control of the higher pacemakers. You can have pacemakers on the AB node. You can have pacemakers firing independently in the ventricle Purkinje fiber system too. Now, similarly, you may have conduction abnormalities where the conduction between different parts of the heart is affected, right? So, if the conduction between atria and ventricle across the AV node is affected, we call it an atrioventricular block, also called a heart block. Now, similarly, you can have abnormal pathways of conduction, right? So, other than the typical AV nodal pathway, this is a disease called Wolff-Parkinson-White, which is a parallel pathway bypassing the AV node. Within the ventricle, it is a branch blocked of the left bundle branch or the right bundle branch block. Then the sequence of depolarization changes because the highway is closed. People have to find alternative routes. Now, re-entry is a very dangerous phenomenon. Typically, there's unidirectional flow of cardiac current, But re-entry is when cardiac current tends to go around a circle, leading to very high rates of contraction or sometimes even ineffective contraction. So we can delve a little bit into what are these cardiac conduction disorders. So we can have disorders of AV conduction, atrioventricular conduction. So typically atria, AV node, ventricle. That is the sequence, right? So in a first degree heart block, there's slowing of AV conduction. So typically this is assessed by quantifying the PR interval, which represents AV conduction time starting from the SA node till the first part of the ventricle. So the normal PR interval is 120 to 200 milliseconds. So if PR interval is in ECG is more than 200 milliseconds, that is a slowing of AV conduction, right? So slow conduction across atrioventricular node. That is called a first degree heart block. Now, second degree heart block is basically a case of partial failure of our atrioventricular conduction. So, all impulses which start in the SA node, some of them reach the ventricle, some of them may fail to reach the ventricle. So, there are two different subtypes based on the probability of conduction. So, in ECG, we can discuss that on a different day. But second degree heart block is a partial failure of AV conduction, where all impulses originating in the SA node will not find their way to the ventricle. Third degree heart block is a complete failure of atrioventricular conduction. So there's no communication between atria and ventricle. So atria will may be fired by SA node, but there will be no communication across the AV node. So the ventricles cannot be controlled by the higher pacemaker. They operate independently at a slower rate, right? The natural rate of the Purkinje fibers or the AV junction. So this is called a idioventricular rhythm. Atria and ventricle operate independently of each other, right? Now we can also have something called abnormal pathways between conduction between the atria and ventricles. So there's a syndrome called Wolff Parkinson White syndrome, WPW syndrome, in which there's an accessory AV pathway bypassing the AV node. So what would happen in this is, because there's an AV nodal delay, this pathway would bypass the AV node and excite the ventricle earlier. So we call this ventricular pre-excitation, right? Now, what are the problems of having an AV conduction failure? So, if this conduction failure, you may have a case where ventricles which are being driven at a higher rate are suddenly not receiving an impulse. So, there would be no ventricular contraction, right? So, if there's no ventricular contraction, it will take around 15-20 seconds for the ventricle to escape from the higher rate which was there before and automatically fire its intrinsic rhythm. So, this 15-20 seconds of time in which the heart is not contracting, cardiac output would transiently fall. There could be decreased cerebral blood flow and there's a loss of consciousness. So, this is called Stoke-Adams syndrome, right? Then eventually around 10-15 seconds later, the Purkinje fibers will escape rhythm and there will be a heartbeat delivered. Right? Now a little bit about disorders of ventricular conduction. So normally any rhythm originating above the ventricle is called a supraventricular rhythm. So the sinus rhythm is also a supraventricular rhythm. So if the rhythm arises either in the SA node or in the atrial ectopic pacemaker or in the AV node, it will be able to enter the ventricle through the AV node. So if you enter the AV node, you can go through the bundle of His, right? Now what is the significance of going to the bundle of His? You can get this rapid depolation of the ventricle, right, which gives rise to the typical QRS complex on the ECG. Now, for some reason, if that bundle of his branches are blocked, you may have slow conduction in the ventricle. We call them right bundle branch block, left bundle branch block. Now, if the rhythm hasn't come supraventricular, right, there's some kind of heart blockade, right, and for some reason a ventricular ectopic pacemaker is now the pacemaker for the ventricles. Now, this ventricular origin rhythm cannot go through the bundle of His. It goes slower through cell to cell conduction, right? So, the bundle of His has only one entry, which is the avinodal supraventricular route, right? Now, a little bit about the more dangerous types of arrhythmias due to abnormal conduction. So, normal conduction is unidirectional, and cardiac action potential is long enough to ensure there's no loops running around. So, cell repolarizes until the next impulse comes. But if there are any patches of slow conduction or any patches of abnormal bypass tracts, you can have a scenario where a cardiac impulse starts here, the same impulse finds its way back across and again goes through. loops and loops. So normally you get one impulse, one ECG wave. But here you can have one impulse, multiple waveforms leading to cardiac arrhythmias. So this phenomenon is called re-entry. So you can have small re-entry circuits within the atria. You can have re-entry circuits across the atria and ventricles across the AV node. So re-entry give rise to a more dangerous arrhythmias like atrial flutter, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. So these would have to be handled. So ventricular arrhythmias like VTAC and refibrillation would need to be handled on an emergency basis. So re-entry is usually one of the causes for some of the higher heart rate arrhythmias. Right. So a quick summary: the cardiac conduction system consists of pacemakers and interconnective connective tissues. So you have the SA node, you have the AB node, you have the interatrial fibers, internodal fibers between the SA node and AB node. You have the bundle of His bifurcation to the left and right bundle branches. Terminal Purkinje fibers achieve a rapid sequence of the activation of ventricles. So, if is a sequence, SA node, atrial muscle, AV node, bundle of His and its branches, and ventricular muscle. So, the sequence of depolarization and spread of excitation across the heart gives rise to the different waveforms of the ECG. Atrial depolarization is the P wave, ventricular depolarization is the QRS complex, and ventricular repolarization is the T wave. Right? So we should know some key timelines which help us in the diagnosis of arrhythmias. So typically, if we start at 0 milliseconds, 30 milliseconds to the AV node, a delay of 90 to 100 across the AV node, and ventricular connection time is very rapid, 80 milliseconds. And as a concept, please remember only a supraventricular origin rhythm can go through the bundle of phase.
Thank you, Vinay, for the wonderful lecture. Very crisp. And what an excellent way to use technology to explain the cardiac conduction system. Uh,
So if there are any
uh,
questions, I would love to handle them, please.
yeah, I don't think there are any questions. Uh, so I have a very naive question for you, Vinay. So but often that the clinicians say that the LBB is any abnormality at the LBB is not that of concern, but it's more concerned that if there is any abnormality in the RBB. Why is it so?
Alright, I think we do not have any questions, so let's proceed to the outro.